One of the great things about these newer targeted therapies, erlotinib and crizotinib, in patients with EGFR mutations and ALK rearrangements respectively, is that we get great responses. Patients have their tumors shrink and feel better relatively quickly. It's very gratifying for the doctor and the patient, and it's something we really love. Unfortunately, we know that the data shows, and we see this in clinic every day, eventually those drugs stop working. How they stop working is something scientifically I'm very interested in, but clinically, when we're in clinic talking with patients, we have a variety of ways that resistance to targeted therapies develops, and it's something that requires a customized approach for each patient. Sometimes what we see is a patient who has a large number of sites of cancer. They all shrink with, say, erlotinib, and then over time, just one of them begins to cause trouble and begins to grow out of proportion to all the rest. And I think that's a good example of something that we could try some sort of local therapy to manage, acknowledging that the targeted therapy is working for the rest of the patient, and it's just one site that's causing trouble. Sometimes that site is in the lung, sometimes that site is in bone, sometimes that's even a spot in the brain. And when I talk about local therapy, what I'm referring to is really any of the things that are non-chemo. So radiation can be used to give focal radiation to one single growing lesion in the bone, one single growing lung lesion, and again, a spot in the brain, one single growing brain lesion could easily be treated with radiation therapy with minimal interruption of the targeted therapy, and then the patient can resume the targeted therapy and hopefully do better. My colleagues at Memorial Sloan-Kettering and I have put together a series of patients in which we did that sort of thing. It's a very select group of patients, but what we've seen is that by doing those local therapy, we can significantly extend the patient's time on that targeted therapy alone and not change treatments as a result of that. Another type of progression that we often see is we see this great response and then very slow hints of progression. 1 or 2 millimeters at a time and several lesions, but nothing's really growing quickly, but everything is just sort of slowly growing. In those situations, I talk with the patient, describe the scans, we go through the scans together, and we talk about the risks and benefits. In general, though, I would say that the benefits of staying on a targeted therapy at that point are great, and the side effects of other therapies are significant, and it's likely that the patient will continue to have slow progression. At some point, it's likely you'll make the decision that you need to change, but I do encourage patients and other doctors as well to consider continuing targeted therapy a little bit longer than we otherwise would. I think one key thing we have to remember is that if a patient has a significant response to therapy, say they have an example of one spot in their lung that measures 3 centimeters, and that tumor goes down to less than a centimeter, even if that tumor goes from less than a centimeter to a little bit more than a centimeter, the patient is still much better off than when they started that targeted therapy. It's a hint that the biology of that tumor is changing, but symptomatically it's likely that the patient will continue to do better even if they just continue on that same targeted therapy. Once we have decided to change therapy, if we've seen continued growth of these tumors or it's clear that there's rapid growth of the cancer, then we have to decide what to do next. Now, one of the dogmas of oncology is that if you have a therapy that stopped working, that is, that we see clear growth of the cancer, then we know that the therapy is no longer working, it should be discarded, and you should move on to the next thing. There are examples where that's not true, though. In breast cancer, patients with estrogen receptor-positive breast cancer continue estrogen receptor inhibitors for a long time after progression on that therapy. Similarly, in prostate cancer, something called androgen deprivation, or where they block male hormones to suppress prostate cancer. In general, those patients remain on that sort of therapy in addition to chemotherapy down the road. So as a consequence, we use those as an example and think that we should continue targeted therapies like erlotinib or crizotinib after patients have progressed, unless we have another targeted therapy that's appropriate for them. But clearly the cancer is growing, so we have to do something else. So in general, I'd add chemotherapy to the targeted therapy to try to extend the time the patient has till the cancer grows, and oftentimes that addition of chemotherapy will lead to significant tumor shrinkage. This is a bit of a controversial view, and many of my colleagues at other institutions feel as though you really should stop the targeted therapy. To try to help answer that question, we look back at a lot of our patients to see on those patients who stopped targeted therapy after evidence of progression. We did this in the context of patients who were enrolling in clinical trials that required them to stop therapy. We looked at what happened to these patients, and we decided to look for something we call flare. Flare, we defined, flare we're thinking of growing cancer, but we decided to set the bar very low in terms of what we defined as flare and said if the cancer was growing enough to cause so many symptoms the patient ended up hospitalized, or in difficult situations the cancer grew so much that the patient died, we called that a flare. And when we looked at about 80 patients, we found that 25%, a quarter of them, had sufficient growth of their cancer after stopping the targeted therapy, particularly erlotinib, that they ended up in the hospital or died. So this was a significant finding to us and really told us that we shouldn't stop these therapies unless we had a clear plan to begin an experimental regimen that seemed valuable or do something different. Now, given that this is a controversial perspective that we should continue TKIs, I think that one way a person could use that data to apply that to this more standard practice of discontinuation of erlotinib is just when you know that you're going to change therapies after progressive disease, patients should continue their erlotinib until they've started the next therapy. So I wouldn't say if you're going to do pemetrexed and carboplatin as the therapy after erlotinib, and you've given the B12 and you're asking the insurance company if it's okay, in that time, while they're waiting for things to get put together, I would say that patients should remain on EGFR tyrosine kinase inhibitors or erlotinib, and then they can continue that for the first bit on therapy, or they could stop it the same day they start, but nonetheless I think continuing most of that time is probably the most rational way to do it.